I would like to introduce our guest from agency, Jenia Vassileva. Her talk will be on patient doses and radiation effects from interventional radiology procedures. Jenia is not medical doctor, so we change a little bit the focus on the interventions, medical interventions. Thank you. And yep.
Thank you very much, Darius, first for the opportunity to be here. Yes, I'm not a medical doctor, I'm a medical physicist. And until 2014, I was a professor of medical physics in Bulgaria. And in the last 10 years, I worked for the International Atomic Energy Agency in the patient protection unit. So I recently retired, and I'm very happy to support the activities like this as an expert now. So yes, as already introduced, I'll change a little bit to the topic of the project, in fact. I'll speak on the patient doses and radiation effects, just to maybe set the background of better understanding what risks we are talking about. And maybe tomorrow, in the second talk, I'll focus more on the practical aspects, how to manage these risks. So this is the outline of my presentation. I think the respected professor speaking before me introduced very well the importance of fluoroscopy-guided interventional procedures, just to highlight once again that these procedures are increasing in the type, in number, and complexity in the recent years because of many reasons, because of the benefits for the patients, for the patient care. And here are the data from the latest NCRPHC report from last year, in fact, 2022 published. It was published in 23, in fact. When we see that interventional procedures have increased in 6-fold increase in number and 8-fold increase in the contribution to the collective dose. You see that conventional radiology has decreased as expected, and the highest increase is really in interventional procedures because of all these benefits. Another trend is the increase of complexity of the procedure and type of treatments. Of course, many of them are performed under other imaging modalities like ultrasound or MRI, but also under X-ray and mostly fluoroscopy. That's why our focus is on fluoroscopy in this project. There is an increase of the complexity of equipment and software used for such kind of procedures, with on one side many dose-saving features of the equipment that also improve image quality. But it also provides many opportunities for increasing patient dose if used without good competence, good knowledge. So, and another trend is the use of fluoroscopy and performance of interventional procedures, but not by only radiologists who usually have good knowledge of radiation, but also by other professional groups. Like cardiologists, vascular surgeons, neurosurgeons, orthopedic surgeons, urologists, gastroenterologists, and very often without any knowledge of radiation at the beginning. So, and performed in a variety of settings, not in only dedicated X-ray rooms, but also in hybrid rooms, operating theaters. Of course, that's another very important point, that in the room we normally have not just professionals performing procedures, but also other staff helping, supporting the procedures, such as technologists, anesthesiologists, nurses. So they all need knowledge and training. We'll return to this tomorrow. Let's focus on the topic of this talk today, on patient dose and risks. I'll start with a very simple description of the patient dose metrics that we are using. Why we need to know patient dose? Of course, because we need to quantify the risk and the radiation risk, not for only patient, for staff. It's normally quantified. It depends on many factors, on the exposed tissues and organs, and what is the energy deposited in the human organs. And we normally measure this in tissue absorbed dose, using the unit gray for this. There are individual factors that also influence the risk, that these are body habitus, age, gender, the health status, and when we have exposure of several organs and tissues, that's normally in the medical applications, we use the quantity effective dose. Effective dose, we can describe this as a tissue-weighted whole body dose measured of risk of exposure with low dose of radiation. We normally use effective dose to only quantify exposure with low doses. If it's high dose, we normally focus on the exposed tissues and organs and measure absorbed dose in these organs. So for this low dose, we use effective dose, and we weight the dose received by different organs and tissues with a specific tissue weighting factors. And these are the factors provided by the International Commission of Radiological Protection in its latest publication, which we use to weight. That means the higher the tissue weighting factor is, the higher is the risk for these tissues and organs. So why we need this calculated effective dose? We need it to be able to compare between different risks. If we put on a scale, for example, we are all exposed by the natural background radiation, and normally in different countries it's between 2.3 to 2.4 millisieverts annually in 1 year from the natural background. Every citizen received. For those working with radiation, the annual dose limit for occupationally exposed staff is 20 millisievert. If we put on this scale the dose received by patient from a single procedure, from diagnostic radiology, nuclear medicine, diagnostic nuclear medicine on interventional, you see here we have a big variation in the doses, starting from very, very small doses and negligible risk to doses that might go above 100 millisievert. Not only from multiple procedure. We have heard from the previous talk that normally patients who have problems from the birth, they are also of course, they will need more procedures, not only these pediatric patients, but many others with complex problems. But also from a single procedure, as we can see here, these are typical doses from fluoroscopy-guided procedures. These are, again, single doses from a single procedure, depending on if these are diagnostic or therapeutic. And you can see that doses can go not just above 100 millisievert, but even above 1,000 millisievert in some very complex procedures. These data are taken from various sources of published papers. For example, this is one of the very recent papers published based on the data from one of the biggest departments in Massachusetts General Hospital in Boston. You see that how big variations, each of these 4 groups are 4 categories of interventional procedures. You see on the right side, neurovascular category 1, endovascular of torso category 2, and then a variety of other procedures in category 3 and 4. And the doses vary between individual patients. In each of these groups, we have huge variations, but also the doses, median doses between 4 categories are also quite different. These are from the same paper, the top 10 procedure with the highest doses, and you can see here some of those with median doses. That means there are individual patients with much higher doses, but median doses in an order of tenths of millisievert from a single procedure. So interventional procedure doses are not negligible. They are the highest maybe in the range from our X-ray procedures, diagnostic procedures. That's why, of course, they are in the special focus. The doses that I presented cannot be measured. So they are only calculated or estimated, but for this we need measurable dose quantities. Before moving to the patient, just to say that for staff or occupational exposure, we have individual dose meters. We don't have such individual dose meters for patients. So that's why in the modern fluoroscopy equipment, there are 2 quantities that are displayed by the equipment: kerma or dose area product and reference air kerma. They are displayed on all fluoroscopy equipment according to the manufacturer standards, and their cumulative values are exported into the procedure report in the so-called radiation dose structured report. So if you are involved in interventional radiology, you have to find these displays because they are different depending on the manufacturer. They are in the room, they are in the control room, and they are also in the report after the procedure. The first quantity, kerma or dose area product, we call this CAP or DAP, is a very good measure of the total energy deposited to the patient body because it takes into account the dose rate, I mean all the exposure factors that are in the center of the beam, but also on the area exposed on the so this is a product of the dose in the center of the beam, in the same plane, and the area of the beam. And what is good, it's independent on the distance from the focus. So we measure this at the X-ray tube site, but it's the same quantity on the patient entrance area. It's used to monitor patient doses, to compare practices in different departments, to set reference levels, and also as a input value to calculate dose to the organs and effective doses using different patient models, using calculation method softwares, mostly based on Monte Carlo calculations. So for just as an example, I mentioned reference levels. This is from one of the European Commission publications, 180. DRLs, diagnostic reference levels in various countries. It's quite old already, more than 10 years old, but this is published as a summary, as I'm giving this as an example. For the coronary angiography, in terms of DAP, we can compare DRLs in different countries or in different, if we have this at a country level, we can then compare between hospitals in the country. So this is from another paper from MGH, also, I think it's the same paper that I used in my few slides ago, but focusing already on individual variations of doses for different procedures. So we use DAP, here we have dose area product as a quantity, to compare between doses performed in different, in different patients, or to compare between different procedures. So this is the objective way, because if we don't measure, we don't know the risk. We don't know how we perform procedure. We need a measurable quantity to be able to compare between departments and between even physicians performing procedures. Another example, also in the same quantity. And the second quantity we are using in interventional radiology, this is a reference air kerma, or cumulative dose, also called. The name changed a few times already, but it's the dose in one point, so-called reference point, for interventional equipment, for example, for equipment, angiography equipment with an X-ray source assembly below the patient support. It's measured 1 centimeter above the patient support, but it could be, the reference point could be different, so you need to check the manufacturer documentation. This quantity is the closest approximation of the skin dose, because we normally don't use, we don't measure skin dose, so it's used to monitor dose specifically at the patient's skin, to compare practices in different departments. Also, we can set reference levels in this quantity and to calculate the real skin dose as well. Normally, this quantity is very well in some of the procedures. It's well correlated with DAP, but not always. It's another example with a bad correlation between peak skin dose and cumulative air kerma, because it depends also, the real skin dose depends also very much on the projections, changing the projections and many other factors. So, of course, we need, the best would be to know skin dose, real skin dose, but if we don't have such an indication, cumulative air kerma is the closest approximation. If we monitor, and these are two examples from MGH and from another hospital in Ohio in the US, Cleveland Clinics, you see that during the years with a monitoring patient, this skin dose, air kerma, the doses decline because, of course, monitoring doses is linked closely to improving practice, implementing radiation protection actions to reduce these doses. I already mentioned that the best would be to know the real skin dose, but in the past, it was only possible through measurements. Of course, we can't measure on every patient. This was used to measure doses on predicted complex cases, for example, occlusion, or some cases that we knew in advance that will be complex, with either TLDs on films or GAF-chromic films that are still used in some places. Nowadays, the most useful technique is to calculate skin dose from the data that are recorded by the X-ray system in the DICOM, and the methodology used by most of the available software for this, because in fact we have two types of skin dose mapping nowadays. Post-procedure, this could be calculated by a medical physicist from the dose structured report, but it's also provided by some commercial automatic dose monitoring systems that are available in more and more clinics nowadays, although they are not mandatory, but they are a very, very good tool to improve patient protection. But in two vendors, they are already available real time. So during the procedure, the interventionalist can see how the skin dose is changing, increasing, and it's mapped. I mean, it's the color map, so they can react. Of course, they will never stop the procedure, but still they might modify something in the procedure. I'll try to describe a little bit more tomorrow to reduce those. So these are the quantities, the metrics we have in our hands, and we are using them to describe the radiation effects. What are the effects? I think everyone working in this area very well knows that we have two types of effects. They are so-called stochastic effects, probabilistic. And these are when cell mutation happens. If these are somatic cells, this can lead to cancer or leukemia. Or if these are germ cells, it could be hereditary defects. When we are having high dose exposure, many cells die, or population of cell, and this may lead to the loss of function of the whole organ or system. And this type of effects we call tissue reactions, or in the past they were called deterministic effects. Now the official term used by ICRP is tissue reaction, tissue effects. So these health effects normally appear, they need time to appear because of the development of this, normally days, weeks, years, especially stochastic effects appears tens of years after the exposure. We know that this effect has no threshold, at least this is what we know nowadays. They are probabilistic, and the probability increases with dose. So we use this as a baseline cancer rate without any exposure or with the exposure to the natural radiation background. And the approach that the current radiation protection system has accepted is the linear non-threshold model. That means without any threshold above the natural background, the probability of this stochastic effect, cancerogenic mostly, increases. And that means as higher the dose, as higher the probability. And this is why the radiation protection aims to reduce doses as much as possible, as reasonably achievable for staff and for patients. So this life risk estimate for stochastic effect, just as an example, just to demonstrate that the radiation is a low carcinogenic factor. So we have in 100 people of the population, 22 to 24 will will die from cancer. 42 will develop cancer in a lifetime. So that means 42% is the natural appearance of cancer. And approximately 1 per this 100 could result from a single exposure to 100 millisievert above the background. So I'm giving this example to say that radiation effects are very low, and that's why we continue using and increasing the use of ionizing radiation in medicine especially, because this is an acceptable risk compared to many other risks for the patient. Tomorrow I'll give more examples for other risks. So what is important, we know that cancer risk depends on the age and sex, especially on the age. Children are 5 to 10 times more sensitive than older adults, and females are a little bit more radiosensitive than males. One more slide on stochastic effects. Very recently, a few months ago, there were 2 papers published from a very large European study, EPCT study, showing cancer risk from exposure to CT in the childhood. Because previously, what I have shown previously, the linear non-threshold model until recently was based mostly on the data from the atomic bomb survivors, extrapolated to low doses. But now we have direct evidence about cancerogenic risk from exposure in the childhood. So this study demonstrated, or the finding shown that the excess relative risk is 1.27 for brain cancer and 1.96 for hematological malignancies. So this is statistically significant increase that is considered to be a direct proof of the linear non-threshold model at low doses under 100 millisievert. But we have to be very careful when interpreting this. What does that mean? That means for every 10,000 children who received one head CT, about one only radiation-induced brain cancer and 1-2 hematological malignancies that are attributable to exposure will be developed. So that means this is negligible, very small risk, but the risk exists. It's a proof that we should take care of the reducing doses. Although the risk is small, we have to aim to reduce this risk. And of course, we have to always consider radiation risk in perspective to other risks. And the respected professors before me already described why interventional procedures are increasing. Because, for example, the risk for coronary bypass is much, much higher compared to the radiation risk. Of course, also, they are non-invasive, they are many more effective very often. So radiation risk exists, and it should not be neglected, but we have to put this in a good perspective. So let's focus in the last minutes I have on the topic of the project, in fact, the tissue reactions. Although, as I mentioned in my comment at the opening, we always aim to decrease doses to staff, doses to patient, because of this radiation cancerogenic risk. But interventional radiology is unique in that sense compared to all other procedures in medicine, maybe only comparable with radiation therapy. The tissue reactions are also possible as a consequence of the use of radiation. It's the same slide, but I'll focus now on the right part, on the high doses, when, because of the high exposure, some cells or population of cell dies, and this leads to loss of functions of an organ or system. Of course, we know that if it's a whole body exposure, it could be the person can die. But we are not talking about this in medicine. We are talking about specific exposure of specific organs and tissues. What is different, we know that these are threshold, there is a threshold dose. Below such a threshold, effect does not occur. So if the dose is under certain threshold, there is no effect. And if we increase the dose above the threshold, the severity depends on dose. These thresholds are not fixed numbers. They depend on other factors, on individual sensitivity. That's why the latest ICRP publication, focusing on tissue reactions, publication 118 from 2012, does not give fixed values. You see that for acute exposure, for example, of the skin, depending on individual factors, between 3 and 6 grays are needed to initiate any reaction of the skin reddening or burn or hair loss. If the exposed organs are, you see, testes or ovaries, it could be also another effect. And important for interventional radiology, especially for staff exposure, is the radiation-induced cataract. The current threshold is 0.5 gray. This has been reduced significantly based on latest data on cataract. And now that's a reason why the occupational dose limit was also reduced. So in interventional radiology, we have a focus on the skin for patient exposure and on cataract for the eye lens exposure of the medical staff, interventional staff. So the first reports, as Professor Walецki already mentioned this morning, from tissue reactions from fluoroscopy started appearing in 90s. 1994 was and the FDA in the United States received a number of reports, and they published this paper in 96 in Radiographics Journal. And maybe this is the most famous case of skin injury after cardiac procedure, cardiac angiography and PTCA, followed at repeat procedures. After this, the FDA issued first recommendations for avoidance of serious induced skin injuries. And following that report, many reports of injuries started appearing in European and American journals, like these cases from the States, and not only from cardiology, but also from neuroradiology and other procedures. Another group of cases from Japan, they were in fact discovered during development of IAEA project, cases from Thailand, cases from Bulgaria. These are cases that my colleague, medical physicist, found almost a year after the procedure from Ukraine. In one of our meetings, we have presentations. So very briefly, which are the factors defining the effect? There are 4 groups of factors. Radiation dose, of course, interval between irradiation for repeated procedures, size of the skin area irradiated, and patient-related factors. Radiation dose, I already presented this. There is a threshold for tissue reaction. And what is important to highlight is that we are talking about skin injuries, but in fact, severe injury can extend up to, can go deeper into the dermis and other tissues. And the severity of the effect and the time of onset depends on the dose. So we classify these kind of skin injuries in 4 groups, 4 classes: prompt, that appear within 2 weeks from irradiation, then early 2 to 8 weeks, and 6 to 52 weeks from irradiation, midterm, and long-term, more than 40 weeks after irradiation. On the severity basis, there are 4 grades proposed to be used. Grade 1, you can see it's a progressive from moderate erythema up to the skin necrosis. So these are, of course, as higher the grade is, more difficult the treatment is. And as mentioned this morning, we need to know if this is radiation-induced necrosis, because it's much more difficult to treat and requires specific treatment. So this is what I have presented in the previous 2 slides, but in a table. So we see here the onset on the right side in different columns, and also the bands depending on the grade of the severity. So the second factor that describes the effect is the interval between irradiation, especially if several procedures are performed to the same patient. Minimum recommended interval between 2 exposures, of course, they are not fixed intervals. If the patient needs immediate second procedure, it will be performed. But if it's possible to plan, it's recommended 4 to 6 weeks if different anatomies will be exposed, or if the same area will be exposed, 8 to 12 weeks to be the interval between procedures. And of course, if the patient already had previous procedure, the skin should be examined before the procedure, and if possible, mark to avoid exposing the same exact area. Then the size of the skin, the small area if the small area is irradiated, it's easy to repair. And that's why collimation is important if we link this to the practical aspects. And finally, patient-related factors. Obesity was mentioned this morning, but there are also other sensitive skin. For example, white skin is more sensitive, and also other factors predisposing to an increased reduced sensitivity. There is a good guidance document by Circe published in 2017, so a group of factors have been mentioned. How often injuries happen? Very rarely, what we know, but we in fact don't know what is the real frequency. In some publications, the reference is to 1 in 10,000 or 1 in even 100,000, but this is just based on what has been reported. And if we calculate on the latest report on the number of procedures, we could expect more injuries every year, but in fact, they are not reported because they are very often missed. The typical scenario that is still valid in many places, after a procedure, patient has problem with skins, it appears normally weeks after the procedure, goes to a GP or dermatologist, not being diagnosed properly, get treated for something else, and the injury worsen. Sometimes patient diagnose himself using internet sources like the case Professor Bolter presented in our technical meeting. This is a case when patient found on the FDA website information and self-diagnosed, in fact. These are the cases from Bulgaria. I come from Bulgaria. This is a case of my colleague, medical physicist, who came across with these two cases almost a year after the procedure. The patient was suffering, going from a doctor to doctor without proper diagnosis and proper treatment. These are two different cases, but the second is specifically difficult. So based on all this knowledge, ICRP back in 2000 issued guidance document and with along other recommendations, follow-up procedure to be established was recommended for such patients. There are also guidance from the Society of Interventional Radiology in the States and Circe, the Cardiovascular Radiology Society in Europe. The IAEA also has pages with information about skin injuries and also a lot of guidance documents. Follow-up procedure is strongly recommended in the safety guide published in 2018. And IAEA also offers more information and a reporting system to collect such cases just to increase the knowledge, and also recommended the trigger values, levels, at the exceed of which we have to follow up patient for skin injury. So you see here they are given in DAP, Kerma, total air Kerma at the reference point, skin dose, or number of serious or senior runs, and some trigger events. These are older trigger levels. They were changed to another list of trigger levels because we didn't have enough knowledge what are in fact real doses, real threshold above which tissue reactions happen. And just for information, until 2021, in this SAFRAT database, there are 319 events reported, 19 of which were recognized tissue reactions. But these are not sufficient information. They do not provide sufficient information to understand if skin injuries still happen and how often, because equipment is improving, experience of the medical professionals is improving. Are these injuries still happening in the practice? So to understand this, 2 years ago, the IAEA planned and initiated and launched a coordinated study with the objective to improve the information about the frequency of the tissue reactions, to study the relationship between reactions and exposure metrics, upgrade trigger levels, and update recommendations. So I'm not ready to present the final results because they are now under analysis. Just very brief and preliminary information. We grouped the procedures in 5. These are 5 groups of high-dose procedures: cardiac, neurovascular, vascular, fluoroscopy-guided tuber therapy, non-cardiac vascular, and non-vascular interventions. And for each of these 5 groups, the local coordinators and the facility level, all facilities around the world were invited to contribute. They have to keep information about patient demographics, procedure type, and dose indices during 1 year. And also to establish a follow-up procedure. I have just 2-3 more slides to finish. And of course, to submit 2 reports to the IAEA, one based on 6 months data collection, and one at the end of the project based on the 12 months data collection. The IAEA provided also guidance and coordination, provided detailed protocol for the study, detailed guidelines for follow-up for patients. So these guidelines can be used to set maybe in the national project. And the whole study that we designed could be used maybe as an idea to launch a national study, because we have only one center from Poland participating in the international study. So this is a good opportunity to enlarge this. So we provided updated trigger values and several training sessions, online platform for data submission, and of course data security was guaranteed, and feedback will be provided. So this is the list of the revised trigger values. And the dose indicators are listed in the order of their importance for the likelihood of tissue reactions. If patient peak skin dose is available at the equipment site, this is sufficient to be monitored. If it's not, reference air kerma is the second good indicator, and only if these 2 are not available, then DAP or fluoroscopy time, because fluoroscopy time is not a good indicator of skin injuries. So this table could be adapted also in the national project. This is the timeline of our study. In fact, we completed with the data collection already, and we are analyzing because it required an extensive information to be collected. Finally, we have only 48 facilities and also ethical approval for submitting data externally. There are many factors, but we have good representation of the world in the study. We have modern equipment, single plan, biplan of different manufacturers. All equipment had displays of those quantities. Skin dose, of course, was not available in all, but still available. Majority of the procedures were cardiac, but also other groups were also well represented. Only one slide with the results, just to show and to confirm that skin injuries still happen, although rare. So 0.8% of all patients have been followed for skin injuries, less than 1% of the patients during 1 year period. And out of these followed, there are 11 tissue reactions. And what was maybe not surprising, but it was the finding, majority of them are from neurovascular procedures. Only 1 cardiac, although we have most of the procedures cardiac. This could be explained with improved safety culture, improved training in cardiac procedures, but that's the reality. We are still analyzing and communicating with the centers to confirm these cases. So I could say that currently we have 1 in 10,000 patients around I mean, skin injury is 1 in 10,000 procedures, but this might change after verification. So to summarize, I'll in fact continue tomorrow, moving to more practical aspects. Skin injuries are rare, but still happening. So there is no chance to miss such an injury if a standard procedure is in place. So this is very important, and I suppose one of the goals of this project is to set follow-up procedure in all interventional departments. So medically unavoidable tissue injury should be as mild and as frequent as possible. Of course, some of them might be just a complication of very complex procedure. Tissue reactions that are not intended should not happen, and stochastic risk should also not be neglected. So we should reduce doses as clinically possible, because tissue reactions are important, but stochastic risk is also real. And this can only be done if we monitor dose indices during and after the procedure. The proposed good practice I'll present tomorrow. And maybe to finish with this message that radiation risk for patient, managing radiation risk is important, but this is one of many other risks for patients, and this should be a part of the routine patient care. I'll finish here with highlighting that still the benefit is the leading in medicine, but risk should always be weighted. And tomorrow we'll move to more practical aspects. I will start with this slide tomorrow. Thank you.
Thank you, Jenia, for complete information on the doses in interventional radiology. This is the comment from. Yeah, but I read in Polish.
Okay.
Well, Grzegorz Frączak, I'd like to share an observation with you. I work in the interventional cardiology lab. I saw the experience of the so-called Krakow school, where technologist, radiologist steers or controls the process, while the physicians focus mainly on providing treatment to the patient and to achieving best results for the patient. The problem of radiological protection is not always a priority. When an experienced technician controls angiograph, the dose administered to a patient may be lower. The physician may focus on his job and be supported by a technician who takes care of radiological protection, which he or she may impact. This is a comment from Grzegorz Frączak, our well, it's hard to disagree with what we have, what I have just read. The problem is that we are discussing radiological protection in interventional radiology procedures, and this project is its goal is to perceive good medical practice also in the context of radiological protection of the patient, not only in the perspective of a particular field of specialization of medical professional. So it's not just the medical process, but also this radiological protection component. And I hope that this project will give us all a better understanding of the good medical practice, seen as a combination of medical treatment, but also radiological protection, seen together, not as two separate components. I'm not sure that what we've just described is what was called the Krakow school of thinking or Krakow approach, but we hope that this change will be taking place, and radiological protection of patients will be included in the whole spectrum of therapy.
Thank you, Darius. Yeah, I want to thank for this comment and fully agree that it's a good practice to have technologists in the room operating the equipment. Of course, it requires very good synchron between the interventionalist and the technologist, but that's not always in case, in fact. So very often interventionalists are performing procedure and at the same time controlling the equipment. So they are different practices, and I fully agree that both technologists and interventionalists should have good knowledge how to reduce doses and how to use properly the equipment. In many centers around the world, cardiologists or urologists or vascular surgeons are using equipment without presence of technologists. And that's something that strictly depends on the country, on the regulation as well. In some places, I know countries where it's not allowed to work without technologists, but that's not always the situation. Thank you.
Thank you very much.